Well, guys, this is Mubin. We're talking about the cardiovascular system general principles. The lecture today is really important. This lecture is about the autoregulation of the blood flow. So let's start. The very first thing to understand is that when we talk about the regulation of the blood, we do not talk about the regulation of the blood pressure. Instead, we talk about the regulation of blood flow over a changing pressure. Now, also understand this thing that we know the the equation for flow equals delta P over resistance. So what that means is that the pressure, so if I have a blood vessel here, let me make that here. If I have a blood vessel here, this is pressure on one end, this is pressure on the other end, and this is the length of the blood vessel, and you know the other things, the diameter and the viscosity would contribute to the resistance. In this blood vessel, the pressure is determined, the flow is determined by the gradient of the pressure, considering that the resistance stays the same, diameter is not changing. When we talk about the flow regulation, what we mean by that is that if the pressure changes, which means that either the volume is changing or the resistance is changing, or in the resistance, the diameter is changing. So the blood vessel diameter is becoming bigger or smaller. When the pressure changes, our body would like to regulate the blood flow. And what is the reason for that? The tissue cells, the tissues consider or need only the oxygen and nutritions and the removal of the waste products. That's all they care for. They don't care for what is the blood pressure in the body. They do not care for what is the diameter of the blood vessels. So the primary key driver is the flow, because flow is responsible to bring the nutritions and oxygen over and take or remove the waste products and carbon dioxide. So remember this as a healthcare professional, the regulation is about the flow and not about the pressure and the diameters. Now, our body is so smart in keeping the flow the same that if we look at it here, and this chart or this graph you would actually may end up seeing in the USMLE and in other examinations, imagine that this x-axis is the pressure. This is mean arterial pressure. We have talked about what is the mean arterial pressure in another lecture. This is flow of the blood. Now, what happens is, let's say this is 70 millimeters of mercury, and this point is 175 millimeters of mercury. Again, this is mean arterial pressure, not systolic or diastolic. This is mean arterial pressure. Our body has this magical quality to keep the flow, blood flow, constant over this range of pressure. So pressure in a blood vessel can change from 70 mean arterial pressure to 175 mean arterial pressure. And even then, the blood vessel and the system around this can continue to have a flow which is constant. So the question today that we're going to answer is, how does that happen? Now, before that, the graph you would see is that the flow reduces. And after that, you would also see that flow increases. So we need to answer a few questions here before we go and see the theories of the flow. Let's say this is the point A, this is point B, and this is point C. So the first question is, what is happening to the flow here? Why is this flow kept constant here? And what happens to the flow here? Why is this flow increasing? So let's answer these two questions, the point A and C, and then B is the discussion that we'll do today. Look, it will be useful if we can actually put a blood vessel here as well. In this area, blood vessel is maximally dilated. It is as relaxed as possible. It cannot relax anymore. That means when you put the blood in it, when you put some blood in it, because blood vessel is really dilated, the flow is really changing as you put more value, and the pressure is not changing because blood vessel is maximally dilated. Now, as the volume increases as the flow increases and as the pressure continues to increase. What does pressure increase mean? That means the diameter would start reducing. So let's say here the diameter of the blood vessel is this much now. So as the diameter reduces and the pressure increases, the flow here needs to be kept constant. So we'll talk how that happens. Then at this point, so as you're seeing that the pressure is increasing, at this point, the blood vessel has constricted as much as it can. It cannot constrict anymore. It cannot close down any further. And because of that, any further pressure changes, for example, by the increased volume coming in, any further pressure changes would cause the flow change as well, because blood vessel is not able to control it anymore. So this also tells us one more thing. The flow change will be governed by the blood vessel's diameter primarily. This is that we are giving that viscosity is not changing, the blood volume is not changing, other physiological parameters are not changing, they're constant. So what is changing is the pressure is changing, and that is changing because of the diameter, and we're trying to keep the flow constant. So now let's see for this graph, how does our body actually work? So first of all, let's look at the types of regulations of blood flow. So there are two types of blood flow regulations. One is called the long-term and the other one is acute. Long-term blood flow regulation is done, and that is not the topic of this lecture, we'll do it separately. Long-term blood flow regulation is done by changing the size and diameter of blood vessels and the number of blood vessels. So bodybuilders, if you see, they'll have blood vessels that are big and that have become long with the tissue as tissue is becoming bulked up. And the number of blood vessels change in them as well, they're more. So that is a long term. It takes weeks to months to years to create that kind of effect. So that's a long term change. Acute change or immediate change responds to the local needs. And why do we need local needs? Why do we not just have big circulation all over the body all the time? Heart cannot take a workload that keeps a very high flow in the body. You actually know that in certain conditions, when there is a shunt or there is beriberi like situations, heart can actually become overloaded and it can start failing. So heart cannot work so much all the time to continue a very high flow under pressure. So what our body does is individual tissues can tell when they need more flow, and that depends upon what kind of work they are doing, and only they will get more flow. This keeps the workload on the heart minimum. So now another takeaway, another lesson here, that the reason for the autoregulation to individual local areas is to keep the workload minimum on the heart. Okay, so now the acute or immediate control is further divided into extrinsic and intrinsic. Extrinsic is where the sympathetic system and parasympathetic system, they come in and control the vascular diameters. So what that means is, if my hand is exercising, extrinsic control will mean this has nothing to do with the substances and the controls here. Instead, the bigger system, the overall systemic systems are controlling the vasculature. So that is extrinsic. Again, this lecture is not about it. The next lecture will be about the extrinsic controls. Today we are talking about the intrinsic control. Intrinsic control means if this tissue is exercising, then this tissue is going to regulate the blood flow to it. This is also called autoregulation because the tissue is regulating blood to its own self. The most important tissues that do that are cerebrum or the brain, coronary vessels, kidney to some extent, and you would also see that the muscles and other tissues can do autoregulations. And we'll talk about all of them separately. Then there is also a regulation of blood flow by vascular system. It falls in the intrinsic category. It also falls in the extrinsic category. So I brought it out as a separate category called the vascular system control on the blood flow. in which there is endothelium-derived relaxing factors and endothelin. We'll talk about that today. We'll also talk about the types of intrinsic controls. There are two theories. One is called the metabolic theory and the other one is called myogenic theory. We'll talk about them today. So all of these we'll talk about today. Now, generally remember this, when these systems are active, metabolic, myogenic and ERDF, they will cause vasodilation. Remember, we talked about it that most of the control is going to come by increasing or reducing the diameter. However, endothelin in normal situation, when it comes in, it would cause vasoconstriction. So keep that in mind and let's start. One more point here, metabolic theory is supposed to be the primary driver of the vessel, local vessel diameter change, and myogenic theory is supposed to be a subordinate theory to it. Myogenic is supposed to be a sub-theory or sub-mechanism that helps the metabolic mechanism. So let's start. Let's look at our diagram here. What we have gotten is this is a blood vessel. We are interested in changing the diameter of this blood vessel to keep the blood flow constant in this area so that this tissue here, the tissue is all around, the whole board is a tissue. The tissue can get a constant amount of nutrition and can get the waste products removed. This cell here is the muscle cell. So you know that blood vessels are surrounded by smooth muscles. So one of the smooth muscle here, what I've done is I've opened it up so that we can look in and see what is happening. At the end of the day, when the diameter needs to change, this muscle either needs to relax, smooth muscle, or it needs to contract. Based on contraction or relaxation, the diameter would either increase or reduce. So as a student, we need to understand what is happening inside the muscle and what factors are contributing to the relaxation and contraction, and that would tell us what would happen to the blood vessel. Okay, so one more thing here. Let's say that the flow is from this side to this side. Also, oxygen is coming in through this area and carbon dioxide is being washed out. This is endothelial cells. I've made them a little bit bigger, and this endothelial cell is showing an angiotensin II receptor on it because we're going to use that. Here on the muscle, these are the T triads, T tubes. This is the internal sarcoplasmic reticulum, which is filled with calcium. There are various receptors here. We'll use the same diagram when we are talking about the autonomic nervous system. We'll use the same diagram when we'll talk about the extrinsic controls. So keep this whole structure together, and this will actually help you in intrinsic, extrinsic, and autonomic controls of the blood vessels. Here we've gotten a sodium channel, and I'm showing this blue area here, which is the cytoskeleton. We'll talk about that in the myogenic theory, but I needed that to be here. Now let's look at this muscle cell. What's happening here? This is a muscle cell. The muscle have muscle contraction mechanism here. We cannot redo the whole mechanism, but what we should understand is this is the myosin fiber. This is the myosin filament. Here is, see these rounded red balls here. This is the actin filament. These actin proteins have gotten these green binding sites on them. Normally, so in this area you can see, normally these binding sites are covered shut by troponin and tropomyosin. So troponin, this thread here, this black thread here is called the troponin protein. What it is doing is it is covering the binding sites of the actin. And these blue things here are tropomyosins. Tropomyosin. These are little cranes. If you give them ATP, if you give them energy, they will move and pull this troponin thread away. That pulling away that you can see here will open up the binding sites, these green sites, and allow the actin to bind with myosin, and more appropriately, myosin head. So here is a myosin head. If you see, we have made 3 myosin heads here. This is a myosin head which has gotten this green area here. I've made that as the myosin light chain. Myosin light chain. Why is that important? That is a primary player today. When phosphate binds with this light chain here, when the phosphate binds with the light chain, that causes this myosin head to become active as well, and it can now connect with the binding site on the actin. So there is change in the protein and the head becomes active and it has a binding site revealed. So here you can see once the binding site has appeared, it will connect with the actin's binding site, and once the two sites are connected, then the head will make a stroke and it will move the filament. After it has moved the filament, the ADP will be separated and the head will go back to the relaxed state. So the contraction mechanism then is really dependent upon ATP, which would drive this structure. Now, for this activity, we also need to understand two enzymes. One enzyme is called myosin light chain kinase, MLCK. And you know it's a kinase. What does that mean? A kinase will put a phosphate on a protein. So this kinase enzyme is putting phosphate where? It is putting the phosphate on the myosin light chain. It would attach a phosphate there. Where will it get the phosphate from? ATP. So that means for the muscle contraction, we need ATP and we need MLCK. That enzyme would pick up the phosphate from the ATP and attach it to the head, and then head will go in a power stroke. Okay. We need to know one more enzyme here, which is myosin light chain phosphatase. This is the reverse of kinases. Kinases attach the phosphate to a protein, phosphatases take it away. So what would happen is that once we've had the power stroke, then this enzyme would take the phosphates out, or this enzyme can independently take the phosphates out and cause the power strokes to not. Okay, so now the MLCP's function is to remove or inhibit the phosphation or attachment of the phosphate to the protein. And so if this enzyme is active, it would cause relaxation. Why? Because the phosphate myosin light chain will not become phosphated and it will not act. Okay, so now let's see how this whole phenomena, how this whole structure works to either enable MLCK or enable MLCP, and that would cause either contraction or relaxation. So let's connect this. Metabolic theory says that the diameter of a blood vessel is controlled by two factors, either the presence or absence of oxygen and the presence or absence of the metabolites from this tissue. So let's say this is the tissue. We'll make a tissue cell over here. Let's say this is a tissue cell. This tissue cell is receiving oxygen, which is coming into this blood vessel, and it is producing waste products, carbon dioxide and other waste products. Okay, now the metabolic theory says that as the oxygen reduces in a tissue that is functioning, that reduction of oxygen will cause the relaxation of the blood vessel and would increase the flow to that area. So let's see how does that happen. Look, let's say this hand is working and the muscles here are consuming oxygen right now and they are producing metabolites that are the waste products. The oxygen lack or unavailability of oxygen part of this theory means this: when the oxygen comes into the blood vessel and the tissue is contracting and working, that oxygen will be pulled away. This oxygen will be pulled to the tissue very quickly. Now, that means this oxygen will not be available as much as it should be for the endothelial cells and the smooth muscle cells that are working within the blood vessel. So what that means is blood vessel itself will not get oxygen and the tissue has pulled the oxygen away. Lack of oxygen in the smooth muscle will cause what? Remember, oxygen is helpful in aerobic metabolism to produce the ATP. So that means low oxygen will mean low ATP. ATP is needed to, number one, convert to activate this tropomyosins to move the troponin thread away, and ATP is needed here for the active heads to work. for the myosin heads to work. So when there is less ATP, this is a direct lack of oxygen. When there is less ATP in the muscle cell, that would mean that this binding and power strokes will not occur and the muscle would relax. So that is the lack of oxygen causing the relaxation. And where did the oxygen go? Go to the tissue. Now, second factor, another lack of oxygen, but indirectly. The second factor is lack of oxygen will cause the tissue to produce metabolites. What metabolites are we talking about? The tissue will be producing adenosine, hydrogen ions, potassium ions, prostaglandins, prostacyclins, etc. So these metabolites that are being produced, their amount of production will increase when oxygen is less. Now, why will that increase? Look, there is some common amount of oxygen coming to this tissue. All of a sudden, tissue started working. The demand increased, but oxygen supply has not yet increased. The flow has not yet increased. So all of a sudden, the tissue started producing these metabolites in greater number. That is one possibility. The other possibility is that somehow the tissue was not doing anything more than normally what it should be doing, but the blood supply got reduced or oxygen got reduced. How would that happen? Let's do that. Let's say I occluded the blood supply. Or let's say I went to a higher altitude. So how will you reduce the oxygen? Go to higher altitude, have carbon monoxide poisoning, have cyanide poisoning, have problem with the hemoglobin, block the blood vessels that are bringing the oxygen, cause pneumonia that would cause the oxygen and carbon dioxide exchange problem. So all of those reasons and many more will ultimately cause reduction in oxygen. So either reduce the oxygen here or increase the oxygen demand. The result will be that when oxygen need is less and tissue is still working, tissue would start producing metabolites. These metabolites in turn would cause relaxation. So let's see how would they do the relaxation. Let's talk about one of them. Let's talk about adenosine. What adenosine does is, if you come here to these receptors, this is the J stimulatory protein here. And this is a receptor that will be acted upon by adenosine. When adenosine connects here, that would cause cyclic AMP to increase. So this side, stimulatory protein receptor, GS, when adenosine attaches there, it causes increased cyclic AMP. Increased cyclic AMP in turn inhibits, AMP in turn inhibits the myosin light chain kinase. So now think about it. When the adenosine is increased, that would inhibit the MLCK. What is the function of kinase? The kinase function was to cause the contraction by phosphating or by doing the kinase active phosphorylating the myosin light chain. The result will be this smooth muscle that is surrounding this blood vessel. The smooth muscle would relax. When the smooth muscle is relaxed, the blood vessel diameter would increase. When the diameter would increase, flow would increase. So that is one of the metabolites. Similarly, other metabolites cause similar actions. For example, prostaglandins, if you see here, prostaglandins will work through the same protein. Prostaglandins also, or prostacyclin also work through the same thing. Histamine has its H1 receptors, which we'll talk about through the nitrous oxide, but we'll go to that in a second. So tissue metabolites will also cause relaxation. Now, let's talk about how can tissue metabolites cause constriction. Let's do that. Let's say that this was the regular amount. Normally, this tissue here produces 10 metabolites in a second, and that's the normal behavior. And those 10 metabolites go and act on the smooth muscle of the blood vessel in the local area and cause certain diameter. All of a sudden, for some reason, the blood flow increased. Maybe I became excited, my heart is now pumping fast, or maybe somebody gave me a drip and my volume is increased. Whatever happened, the flow has started increasing. As soon as this flow increases, it would wash away these metabolites. IV infusion or whatever reason, the flow increased because of excitation, the stroke volume increased, the force of contraction of the heart has increased. Now, when there is more flow, that would pull this and it would suck away these metabolites faster. So now the tissue is not doing extra work, but that little pile of metabolites which is normally present is gone, is washed away. When that is washed away, those metabolites are not going in and acting on this system and not causing the normal tone that they cause, and the muscle would now, instead of relaxing, it would become contracted. Why? Because metabolites usually go and relax the muscle. So that means if you increase the flow unexpectedly, and you give more flow to a tissue than it needs, it would constrict its blood vessels and reduce the flow. And if you reduce the flow to a tissue than what it needs, then it would open up the blood vessels and increase the flow to it. So this is the effect of the metabolites. Now let's also talk about one more metabolic system here that really has an interesting action, and that will be the calcium here. We're talking about the calcium here. Calcium is not directly affected by this, but we know that when there is a nerve impulse, so let's say this is a nerve, when there's a nerve impulse that causes the neuromuscular junction to have the excitation here, that would end up causing the T tubules to be connected to this triad, and ultimately calcium will be released. Calcium acts on the MLCK and activates it, and that would mean that the muscle would contract more. This also happens with the G receptors. So this GQ receptors here, which are alpha-1 receptors, they are also endothelin and angiotensin receptors. What they do is they increase inositol triphosphate. That causes calcium to be released, and calcium then in turn will cause the contraction. All right, so that is the metabolic theory. Let's talk about the myogenic theory. Myogenic theory says that the muscle itself also, this muscle here around the blood vessel, the muscle itself is also responsible for its own control of contraction and relaxation. So let's see how does that happen. Let's look at the channel here. Let's say this is a sodium channel in the smooth muscle. And we know that depolarization, as we just talked about it, when the excitation comes in, that would cause the sodium channels to open up. The cell would become depolarized. That depolarization would cause the calcium to be released, and that calcium would cause the contraction to occur. Now, in this particular case, this sodium channel is closed, and this sodium channel is connected to cytoskeleton. So this is really important. This theory would not work without this concept. Cytoskeletal, the microtubules of the cell, are connected to this receptor, and it is normally closed receptor. Now imagine, for some reason, there is a greater amount of blood volume pushed into this blood vessel. Flow has increased for some reason. Maybe my heart has started pumping more. Now, as the flow increased, that would stretch everything here, including this muscle that is wrapped around the blood vessel would stretch as well. That stretching would cause microtubules to be stretched. Those stretched microtubules would pull this receptor open. They will pull the receptor open, and when the receptor will be open, then let's say the receptor has become open because of the mechanical pull that would cause the sodium to go in. The sodium going in would cause depolarization, calcium would be released, calcium would cause a contraction, and as the muscle contracts, it would recoil the blood vessel. It would reduce the diameter to reduce the flow. Reduce the flow to what? Towards normal. The flow had increased, we have reduced it back towards the normal. Why? Because the tissue did not need extra flow. So that is the myogenic theory, and the vice versa. If for some reason the flow reduces, that would cause more of such receptors to close down. That would cause unnecessary depolarizations or static depolarization or baseline depolarizations to go away, and the muscle would relax, and that would open up the blood vessels. So this is the myogenic theory. However, please remember, myogenic theory cannot explain reactive hyperemia. So we'll talk about it in a second now. Reactive hyperemia is a process which is, so metabolic theory also explains two more things, and these two things are active hyperemia, and reactive hyperemia. What does that mean? Active hyperemia is simple. As a tissue starts exercising more, as a tissue starts working more, there is more blood flow to that, and so the tissue becomes hyperemic or red because the blood flow is more. So that's what we just talked about. Oxygen consumption and the metabolite production would cause active hyperemia. Reactive hyperemia is that the tissue, so let's say you were working on this tissue was working and I closed the blood vessel to it. Or the tissue was not doing anything, but still the blood vessel or the blood flow is occluded. Now the tissue is producing waste products that are not getting washed out. When you leave the blood supply, when you open the blood supply, now for some time, the blood flow will increase to this tissue. Tissue is not doing anything. It just had more metabolites sitting in it. Why would that blood flow increase? Because of the metabolic theory that explains it, that there are more metabolites. Metabolites cause the relaxation of the muscle that would open up the diameter, open up the blood vessel, and the flow would come in. This kind of activity, increase blood flow to a tissue after occluding the blood flow or reducing the blood flow, is called reactive hyperemia. This is also is governed by the law of compensation of the blood flow. The end result of this one is that we've gotten the increased blood flow. So myogenic theory does not explain that. Why does the myogenic theory not explain it? Because myogenic theory needs the muscle to be stretched. Here the muscle is not stretched. It's just the extra metabolites present in the tissue. So myogenic theory is definitely something that is a mechanism available, but this is a subordinate mechanism to the metabolic theory. So we're done with these theories. Let's very quickly go through the ERDF and endothelin. ERDF or endothelium-derived relaxing factors are the factors that are chemical substances released by the endothelium, which would cause the muscle around the blood vessel to be relaxed. Now, the most important one out of these is the nitric oxide. Nitric oxide. This is released by the endothelial cells. So how does that happen? There are multiple factors that can cause the nitric oxide to be released, but let's see the one that is really interesting and important, and we'll talk about the others later on. The shearing effect. If you increase the flow through this blood vessel, that would cause these cells to be dragged with the flow because of the viscosity. So let's say we'll take this cell. Let's say this cell becomes dragged. Of course, all of the cells are becoming dragged. That is dragged with the blood because blood is flowing fast. That shearing effect, just like over here we have a cytoskeleton, we have a cytoskeleton in here as well. That shearing, the pull, will cause internally the nitric oxide to be released. Nitric oxide, when it reaches the smooth muscles around this blood vessel, that is being, the blood vessel that has the shearing effect or increased flow, then the nitric oxide does something that is interesting here. It goes and it blocks the cyclic GTP to become cyclic GMP. Cyclic GMP then inhibits. So did I say block? It actually promotes the formation of cyclic GMP. Cyclic GMP then in turn blocks the MLCP. MLCP, what is its job? It causes relaxation. So when MLCP itself is blocked, then the contraction would occur. So what would that mean? As a contraction, this smooth muscle would contract, the flow would reduce, and the shearing effect would reduce. So that is how the nitric oxide will function to cause the contraction of a smooth muscle. Now, how can nitric oxide be released? It can be released for many factors. One is this mechanical factor. Angiotensin 2. So this is an excellent doctor point. You know that when angiotensin 2 connects with the smooth muscles here, this is the angiotensin this receptor, the GQ receptor, when angiotensin actually directly acts on the smooth muscle, it would cause the contraction of the muscle. It's a powerful vasoconstrictor. However, when angiotensin 2 acts on the endothelial receptors, then it would release nitric oxide from there. And that nitric oxide would cause the vasodilatation by relaxing the smooth muscle. So what is the benefit of that? The benefit is that angiotensin kind of balances its own self out. It knows I'm going to cause the vasoconstriction by contracting the smooth muscle, but it is afraid that it's going to cause too much contraction and the blood flow would occlude. So what it does is it also promotes the formation of nitric oxide to create a balancing relaxation. So that is how angiotensin 2 can actually participate in vasodilatation. So keep that in mind. There is one more interesting thing here. The nitric oxide release by sildenafil. Remember sildenafil, Viagra, it is for the penile erection. So the people who have the problem with the erection, they use this sildenafil. What happens in that case is that the enzyme that breaks down the cyclic GMP, the PDE5, that enzyme, phosphodiesterase 5, this enzyme is blocked by the sildenafil. And so when that enzyme is blocked, then what happens is that there is increased quantity of cyclic GMP. So when nitric oxide is released with the parasympathetic stimulation to the penile blood vessels and acetylcholine is released, acetylcholine and acetylcholine and the other parasympathetic stimulation would end it would result in producing the nitric oxide. Nitric oxide would go and have lots of cyclic GMP. Lots of cyclic GMP would cause the blockage of the MLCP, and so the vessel would relax, and that would cause the engorgement of the muscle tissue, and that would cause erection. So that is how that works. Now let's look at the endothelin as well. Out of all of these are physiological mechanisms. Endothelin is the one that is a pathological mechanism. So what happens is, if for some reason the blood vessel is crushed, if there is a damage to the blood vessel, that damage, for example, due to an injury, would cause the tissue to release and the endothelial cells to release endothelin. Endothelin then acts on the local receptors. So Q receptor here is the endothelin receptor. Endothelin acts through the GQ receptor, and what does it do? It inhibits the MLCP. So when it inhibits the MLCP, relaxation goes down, contraction increases, and this blood vessel contracts. Why would it do that? Look, there is an injury, there is blood flowing out, there is bleeding. To reduce the bleeding, we need endothelin so that the blood vessel would contract and the blood flow to this part which is injured would reduce. So guys, one more point about the ERDF. What is the purpose of the ERDF in the local blood flow? Look, if I make a little structure here, let's say this is a blood vessel that is bringing blood to 3 tissues, tissue 1, tissue 2, and tissue 3. And then the blood is going back. Let's say tissue 1 is the hand. Let's say this is that tissue. And it starts working more. Do you think that we should get the blood to all of the tissues, all the rest of the arm or the rest of the body to have more blood flow as well? No, we just want this particular tissue to get more blood. So yes, it is going to cause the local vasodilatation by the metabolic theories and myogenic mechanics. The local vasodilatation will occur, but by doing the ERDF or by releasing the endothelial relaxing factors, what this tissue and the blood vessels of the tissue are doing is they are dilating the upstream blood vessels as well. So now the blood vessels above are also dilated. The benefit of that dilatation is that this tissue is now getting more blood flow compared to the others. So others are still having the same level of blood flow while this tissue is getting more blood flow. So tissue not only opens up the blood vessels. A working tissue not only opens up the blood vessels where the work is happening, but it does open up the blood vessels a little bit above as well, so that more flow can be diverted to that tissue. So that is the benefit of EDRF. Thank you very much.